So now I'd like to introduce our next speaker. Dr. Jason Starr is a medical oncologist. He specializes in GI malignancies. Um, his clinical and research focus on neuroendocrine tumors. He also does clinical trial development of novel targeted therapies, immunotherapy, and radioscope based therapies, and is a believer in multidisciplinary approach to cancer care. So, without further ado, welcome, Dr. Starr.
Thank you so much, Bob, for the warm introduction, and so happy to be here with you all on this spring Saturday. Thank you for putting aside the time to be here to learn more about this disease and all the exciting breakthroughs that are going on to support each other. I thank NCAN for having me and involving me in NCAN. I think that you all are doing some wonderful work, and I'm very honored to be here. I wanted to also say thank you to Dr. Shahan for inviting me as well, and his presentation was superb. I really appreciate and support all the work that he's doing, and very proud of him. He's making some waves, and he's working really hard. So with that being said, I wanted to do an overview of treatments for neuroendocrine cancers. Obviously, within 20 minutes, it's going to be a high-level view, and we will, I want to make sure we leave time for questions, because that's really an important component of these conferences, because we want to interact with you. We want to know what's on your mind. We want to know, what burning questions you have that we can answer. So let's get going. So how do we determine treatment? So for the purposes of our discussion here, we're going to talk more about advanced or metastatic disease. For localized disease, surgery is the mainstay. So if somebody had presented with a small bowel neuroendocrine tumor, and the most common place, the terminal ileum, surgery would be the primary modality for treatment. And as we embark on determining treatment, we need to identify where the neuroendocrine cancer started. Did it start in the small bowel? Did it start in the lung? As Dr. Shahan said, it can start in a number of different places, the thymus gland, the rectum. And that's really important to help determine treatment, because not all neuroendocrine tumors or cancers are created equal, as you learned with Dr. Shahan's wonderful presentation. And then we need to identify the biology of the neuroendocrine cancer. What's the grade of the cancer, as Dr. Shahan touched on? Is it a NET or a NEC? A neuroendocrine carcinoma. Nomenclature is key. And I really press that upon my patients. They end up being experts in their own right in really knowing more about this disease than the general medical community. And I'm talking about doctors. So I'm really proud about that, and I really like empowering patients. So more about how we determine treatment. Is the cancer causing symptoms? Are they carcinoid syndrome type symptoms, such as flushing and diarrhea? Could it be, are you having pain related to the cancer itself? That may change what kind of treatment we recommend. And ultimately, you, the patient, are at the heart of everything we do. So it's important that we involve you in the decision. Shared decision making is really, in my mind, the only way to find treatments and to agree on treatments that are going to work. Because, if I say a treatment, it only carries so much weight. You as the patient need to buy in and understand, what we're doing and what we're trying to accomplish. So I really want to stress that upon you, to be involved in the decision making. And if your physician doesn't involve you in the decision making, ask them. And if they don't, work with you, then, unfortunately, I think you sometimes need to find another doctor. So this is what I'll quiz you on later. I'm just kidding. But this is just a slide that I made at some point, and just kind of shows the nuances and the complexity of what goes into making treatment decisions. I'm not going to get into this. It's just for purposes of, showing how complex it can be. So as I said, it's complicated, and determining the right treatment at the right time involves thought and discussion. Please don't be afraid to ask questions. And some basic principles that you should walk away with from your visit with the doctor is you should be able to understand the basics of how the treatment works. works, and you know what to expect of the expectations of the benefit, and then the side effects. So at least those three tenets you should walk away from the visit understanding. So getting treatment started. So I always, obviously, in reviewing the symptoms is your symptoms and how you're feeling is of utmost importance. The scans, the labs are second nature. We want to know how you're doing. PET imaging, as Dr. Shahan emphasized, is critical. I didn't include the copper. We haven't used it at Mayo yet. It does have some potential advantages. It seems to have as good sensitivity and imaging quality. It has a longer half-life, meaning that you could ship it and it stays active longer, the radioisotope. So there could be a lot of benefit there for the copper 64 radioisotope. And then I do recommend dedicated imaging of the liver if appropriate. I prefer MRI. We'll talk about if your physician is considering a CT, what he or she should be aware of when ordering that test. You want to check your kidney function, your liver function, biomarkers. Dr. Shahan is working on the progastrin, and he's done a lot of work with his group with trying to find better biomarkers. Some of the biomarkers that I listed here are controversial. We always talk about chromogranin A and how much we like or don't like it. A lot of us are just ambivalent about it. It's there. We've used it for a long time, but the reality is it's not a very good biomarker. The urine, and I use more recently a serum 5-HIAA so that patients can dump the jug and not have to carry that around for 24 hours and store it in the refrigerator. So talk to your provider about that as a possibility to get a blood test instead. And then an ultrasound of the heart, or we call an echocardiogram as appropriate if we're worried about what we call carcinoid heart, which is damage to the heart that can occur from long-term serotonin exposure. So here's just an example of gallium-68 dotatate PET imaging. As you could see here, there is a mesenteric mass. A lot of times, small bowel tumors will track up the vasculature, which we call the superior mesenteric artery, and come more centrally here. This patient also had a liver mass and a little one at a smaller mass at the dome of the liver. But you could see, it really highlights the disease as compared to the rest of the body. Here's the heart and some blood vessels and the bowel, and these really jump out at you, because they are, bright. The treatment approaches, and as Bob alluded to, I'm a big fan of, a multidisciplinary approach. And surgery is still an important part of treatment when it comes to managing advanced disease. And occasionally it's recommended that we say, well, some patients will benefit from surgery to remove disease in the liver, although it may be stage 4 or advanced, and that is a discussion that sometimes need to be had. Just have to be very selective and be careful on which patients that we recommend undergo surgery. For example, if there's a tumor in the small bowel and you're experiencing signs and symptoms of obstruction, that would be an opportunity maybe to do surgery to remove this tumor. Dr. James Howe is I think you've probably heard him speak before. He's a surgeon at the University of Iowa, is a proponent for doing surgery even in the absence of symptoms to remove the primary tumor, but that's a bit controversial. And like I said, the presence of stage 4 or metastatic disease does not exclude you from being a candidate for surgery, but you just have to be very careful which patients we recommend. So liver-directed therapies as a treatment. If there is disease in the liver and primarily in the liver, we do consider liver-directed therapies in some patients. We use the fact that the neuroendocrine tumors in the liver mainly use the arterial blood supply their blood and their nutrients and their oxygen that we'd like to deprive them of. And the local therapies go up through the hepatic artery circulation and treat the tumors that way. There's different local therapies, and we call them different things. There's bland embolization, there's radioembolization, there's chemoembolization. We've been using more of the bland embolization, which just is really gel foam that's put into the artery to just deprive the tumor of arterial blood supply, oxygen. With some cases, we do radioembolization, where these little radiation beads go in there and destroy the tumor cells. And it's a really, again, multidisciplinary discussion. We would discuss your case at a tumor board and decide what the best local therapy would be for you. I'm not going to get into too much of the details on the differences of the local therapy. So this is an example of why, if you are getting a CT scan of the abdomen, it's important that your physician includes an arterial phase. Again, as I alluded to, the tumors primarily hijack the arterial blood supply to allow for growth, allow for their oxygen and nutrients to be provided. And you could see on the venous phase here, can't really see anything. I don't really see any tumors. The liver looks a little bit what we call cirrhotic, a little shrunken. But in the arterial phase, you see these ring enhancing lesions that are indicative of tumors in the liver. So it's very important, if you get a CT scan of the abdomen, to ask your clinician, your physician, to include an arterial phase to evaluate the liver. So treatment approaches, I'm going to focus on the somatostatin analogs because they're really a mainstay. They come in short-acting and long-acting formulations. The short-acting somatostatin analog is what we refer to as octreotide. It now comes in a nice pen, which has been really convenient, although there has been a shortage. I haven't seen when that's coming to an end, but almost like an insulin pen delivery system that you don't have to refrigerate and is really more convenient. So we use that more often to treat symptoms related to carcinoid syndrome, whether it be diarrhea, flushing, so on and so forth. And then there's two somatostatin analogs, which I've abbreviated SSA, that we use that are long acting, that we do once a month, although that could be changing. We're still studying the frequency and the ideal frequency. And there's lanreotide, or Somatuline is the brand name, and then octreotide LAR, or Sandostatin is the brand name. So somatostatin is a naturally occurring hormone. So this is a synthetic hormone that's been made to be an analog to the normal hormone that you have in your body. It's produced by the pancreas, duodenum, pyloric antrum, which is in the stomach. And it's an inhibitory hormone. It helps regulate digestion and other hormones, such as insulin and glucagon. And it was discovered by some really smart people that the hormone also inhibits growth within neuroendocrine tumor cells. So that is kind of how it became a mainstay treatment. Originally, we developed it and we used it mostly for symptom management of the carcinoid syndrome. And then later it was identified that it actually has some what we call tumorostatic, or it slows the growth of the cells. So it's fantastic. It can be difficult to determine when to start these agents. Just because there is a neuroendocrine tumor that's identified, even in the stage 4 setting where it's spreads to the liver or some lymph nodes, it doesn't always mean that it's time to start the somatostatin analog. And so it should be a really informed decision. You watch the tumors on the scans and determine, when the right time is to start the treatment. But observation is not always the wrong answer. It could be a little unnerving to do observation, and if observation causes anxiety, then definitely, that can be taken into consideration on when to determine when to start that somatostatin analog. So the Somatuline, or the lanreotide, is given as a deep subcutaneous injection. The Sandostatin, or the octreotide LAR, is given as an intramuscular injection. And don't be afraid to ask your physician for some lidocaine cream or even a lidocaine patch to help reduce the pain. I started adopting that practice more recently, and I give it as an option. If you're dreading the shot and it hurts, let us know, and we can do something to help you. So potential side effects can be diarrhea, can be acute diarrhea for the day of and a few days after the injection, can be chronic diarrhea. One undertreated, underappreciated diagnosis is exocrine pancreatic insufficiency. Remember, somatostatin analogs are inhibitory. It's an inhibitory hormone. It makes the pancreas lazy, is what I say. And so when you're eating meal and you need to digest your food, sometimes the pancreas isn't there for you. And so sometimes we have to give pancreatic enzymes to help with digestion. And actually, more often than not, I would say 80% of the time, I have patients on pancreatic enzyme replacement. So bring that up to your physician. If you're having diarrhea, loose stools that float on the surface, are greasy, bloating after eating, a lot of gas after eating, those are all signs and symptoms of pancreatic insufficiency. And then we have nausea as a potential side effect, gallstones, which is something you have to be on the lookout for, and then blood sugar variations. It can go high, it can go low. I see it go high more often than low, but I've also seen low. Unpredictable in that regard. A big difference in the course of this disease. It's currently approved for grade 1 and grade 2 bowel and pancreatic nets. There is data on the use in grade 3, and I have got it approved by insurance companies for the use in grade 3 disease, both neuroendocrine tumor and neuroendocrine carcinoma, but namely for tumors with a Ki-67 of less than 55%. That's where it seems to at least have most of its benefit. I would be, it's one thing to do something, it's another thing to derive benefit and have you know, uh, have value in the time that you're taking and all of everything you're undergoing that actually works. It's currently approved for after somatostatin analogs are no longer working. However, this is probably subject to change with clinical trials in progress, such as the NETTER-2 trial that's, I think, already up and going. But it's a breakthrough treatment. It works better for some than others, and that's true of any treatment. And we're going to be working on predictive markers and models to determine who will benefit the most so that we can kind of help ahead of time prepare you for, hey, we really think this is going to be beneficial, or hey, this may be a marginal treatment that may not have as much benefit as we would hope. So how does it work? And I'll because I think we're coming to the question and answer portion here pretty soon, but I'll say that we exploit the fact that neuroendocrine tumors overexpress somatostatin receptors. It's about greater than 90% in well-differentiated bowel and pancreatic nets, 50% or so in lung nets, and depending on the literature that you look at, it's up to 70% in neuroendocrine carcinomas. Just because the receptor's there doesn't mean the therapy is going to work or work for a period of time that we would hope. But this is a whole field called theragnostics. And so we use the receptor on the tumor cell and we exploit it, whether to do imaging, as I'm showing here, the gallium-68 dotatate, or whether to do the treatment, the lutetium-177 or the Lutathera. And Lutathera side effects, as I said, one of the basic tenets you want to ask your physician is, what are the side effects? So nausea, vomiting, abdominal pain, diarrhea, fatigue, usually they're mild. And you could see I put some of the percentages here for the more, intense symptoms that you could experience. But we've gotten better with anti-nausea medications. I would say nausea and vomiting is very low, much lower than reported in the NETTER-1 trial, which is what I used here to get these numbers. You do want to know, and you do want to talk to your physician about the risk of leukemia, or what we call myelodysplastic syndrome, which can occur up to 2% of patients, at least in this trial. We're trying to identify, we started a project at Mayo Clinic to identify patients who will be at higher risk for developing myelodysplastic syndrome to better counsel those patients ahead of time. So future directions for PRRT will be improved selection of patients, as I mentioned, new radioisotopes that you may be hearing about in the news, like alpha particles, antagonists, and radiosensitizers. And our very own Dr. Shahan has a trial right now through the NCI where he is looking at a medication called treapine to see if it helps the PRRT work better. So maybe we can get him to talk about that a little bit. And then PRRT retreatment, which is something that is new, and we've treated, maybe almost 20 patients in the Mayo Clinic system as a PRRT retreatment, because we don't know that 4 treatments and that's it. because that's typically what we do is 4 treatments, that was a bit arbitrary. So we're still wondering, if we can do more treatment, and is that safe? And so far, it appears to be safe in our hands. So I'm not going to get into a lot of the other therapies just for, it just would be a lot of time, but for pancreatic neuroendocrine tumors, certainly chemotherapy can be considered. There's non-chemotherapy options, but as you can see here, there's a lot of options. And so make sure, you're talking to your doctor about these options and which one might be the best for you and at the right time. So that's pancreatic neuroendocrines. For small bowel neuroendocrine tumors, there's non-chemotherapy options, there's chemotherapy options. But as Dr. Shahan said, we're trying to move away and be smarter about how we do treatments, and we want to reduce side effects. We want you to have better quality of life. And then I don't want to neglect neuroendocrine carcinomas, as Dr. Shahan said, that this is a bit of a neglected entity. And I'm really happy to hear about all the research he's doing in this field, because we need better treatments. It's been carboplatin and etoposide for a while. You can consider capecitabine and temozolomide, and the treatment decision is typically dependent on the Ki-67, as Dr. Shahan had shown. And then for patients with a Ki-67 less than 55%, you could consider PRRT. It just depends on the uptake that you see on the dotatate scan, on the PET scan, and you just have to be very selective and careful about recommending that treatment. Because again, it's one thing to do something, and it's another thing to, we want to make sure that you're going to benefit. Immunotherapy has also been of interest in neuroendocrine carcinomas. The results have been variable at best, and that would be an understatement. We looked at immunotherapy in the Mayo Clinic of patients who received it with neuroendocrine carcinoma, and we've been underwhelmed and not very impressed. There was a trial called the SWOG 1505 trial, which was the DART study, that did show some more promising data to suggest immunotherapy may work. But I think it's going to be a little bit more time before we know how immunotherapy works and if it works in this setting. And then I would be remiss if I didn't mention clinical trials. It's important to consider clinical trials along the way. It's the only way that we can discover better treatments. And so if your physician does not bring up clinical trials to you, always feel free to say, hey, what about clinical trials? What is out there? Is anything appropriate for me? Do you have anything here at your institution? So I think that you should definitely, it's the only way we're going to move the field forward. And that's the end of the talk there. So I'm looking forward to taking some questions, and appreciate your time and attention. And thanks for having me.